Now we move on to our next session, that is this far, no further, how to balance between invasive and palliative care in Onco ICU. So to chair the session, may I request Dr. Rajiv Goel, Senior Consultant Respiratory Medicine at Rajiv Gandhi Cancer Institute, and Dr. Kapil Singhal, Senior Consultant Anesthesia and Head Critical Care and Deputy Medical Director, Metro Hospitals and Heart Institute, Noida. Welcome, sir. Yes, sir.
Hello, hello.
Yeah.
Yeah, it's working. Good afternoon, everyone, and thanks for having us here. This is Dr. Parveen. She's there. Okay, thank you for having us here, and very nice conference. You can see this is going on since morning. So, coming to the topic which will be discussed now is a continuation, I believe, of the panel discussion which was going on. And we also have in continuity the panelists from the previous discussion, Dr. Rajesh Pandey, a very renowned intensivist. I mean, he's been there for so long, as long as I can remember, and has headed many, intensivist conference and, conducted many of them. And he'll be talking about, this far, no further. I think this is a very, very sort of pertinent phrase as far as intensive care, for oncology patients. And many a times the dilemma of, how far to go, when to sort of stop, and when to actually say that this much and no further. So that is the call that the intensivist has to take. And like the panel discussion which was being held before this, the important thing I think is, there is a science to it and there is an art to it. The science tells you about looking at the numbers, looking at various things which tell you about the patient. But the art of is to look at the patient, to look at his family, to look at his overall situation in life, to also look at his oncological status, where he is in terms of his, trajectory as far as the disease goes, and then take a call as to, what you should do. So I think the patient's family is perhaps very, you can say, ignorant of what can be done, and what should be done, when to leave aside and when to, do further. It is the job and it is incumbent on us to actually inform the patient as to where the, the patient, what is the situation, tell the family where it lies, and then, take a common decision. So Dr. Rajesh Pandey, I'm sure, will, deal with all this in detail. And welcome to you, Dr.
Thank you so much, sir, for the kind words, and I think he has very nicely summarized what I'm going to discuss. So, and the title is very, very suggestive, This Far, No Further. So, it talks about a situation where we have reached a medical futility in terms of treatment or therapeutic options or the progression of the disease. So, because we have a mixed audience, earlier the palliative care was, discussed only in context of oncology. So you can see there are two models here. So initially you are trying to treat with a curative intent. When you find that disease is far too progressed or it cannot be cured, then the palliative care time starts. And then towards the end of the time, when you know that patient is not going to make it, possibly you will be discussing with end of life situations and what are the withdrawal options or withholding options. And then you also provide bereavement care to the family. Similarly, another model, again focusing on oncology patients, it refers them to the hospice care. Unfortunately, hospice services are not so well developed in India. So after palliative care or after discussion with the palliative consultants, they are often referred to the hospice care. So there were a lot of gaps in the advanced cancer care, which were because of misunderstanding of palliative care, that palliation should come only when curative ends. That was one misconception. and poor communication regarding the diagnosis and the prognosis, all those things, and the lack of advanced care planning discussions, that this is going to be the option, we'll do this, and then we'll continue with the supportive management and symptom management. Also, they were confused about involving the family physicians. Once the family physicians has referred to a hospital, his role in India stops. So he is the person who has been looking after, has been in touch with the family, so he should very well be part of the ongoing treatment journey from curative to palliative and finally to end of life care issues. Poor care coordination between different stakeholders, which was highlighted by previous speakers, that if the patient, which Prakash highlighted, Prakash Shastri, that when the patient comes to me, suddenly I am the boss, whereas he has been in touch, constant touch with the oncologist for almost a year or two. So suddenly the care is transferred to me, who is an unknown entity for the patient. If you look at the global scenario, there was this group which identified what is the global ranking. India ranks 59th out of 80 countries in terms of our understanding of palliative care. That means awareness is very, very poor, possibly because in our society we are afraid and reluctant to openly discuss issue of death. WHO has defined, now please understand, now they have expanded its horizons to include all terminal situations. So they understand they define it as a crucial part of integrated people-centered health services. Relieving serious health-related suffering, be it physical, psychological, social or spiritual, is a global ethical responsibility. And this suffering could be cardiovascular disease, cancer, major organ failure, drug-resistant TB, severe burns, end-stage chronic illness, acute trauma, extreme birth prematurity, or extreme frailty of old age. Palliative care may be needed and has to be available at all levels of care. So this is the change that we have to make in our thinking, that it is not only related to oncology. It started with oncology, but now it encompasses all these kind of situations where we cannot offer much in terms of care. Globally, only 14% of the patients who actually need palliative care receive it. So this is what I was talking to you earlier, that intensive care is technical medicine. We connect a lot of things, we measure a lot of things, whether they are really benefiting the patient or they are only benefiting the residents in terms of data interpretation. Palliative care, on the other hand, has been mistakenly labeled as a talking medicine, where you are doing nothing much, you are only talking to the patient, counseling the patient, having family sessions. In palliative care, the literature mentions that you can have primary palliative care, where care is provided by the intensivist or by the oncologist, who are not specially trained in palliative care. Specialty palliative care is where persons have been, or people have been trained, or they are qualified palliative care specialists. They have been trained and they are labeled as palliative care clinicians. I do not know whether you have one in Rajiv Gandhi, because we don't have any palliative care clinician in our hospital. We do it, so we are the primary palliative care driven model. But there is a significant overlap between the two, that is intensive care and palliative care. So you cannot segregate the two. So these are the two models that you can see. So this one is the traditional model, where there could be an integrated model, or there could be a mixed model. The pediatricians in PICU have come up with an escalation matrix, or a pyramidal model, where they say that initially we can handle, and subsequently we can have champions within the unit who can start these discussions, and finally in certain situations we need a specialty palliative care consult. So these are the models that are in vogue. Intensive care, we need to understand, has lot of limitations. We want to maintain the patient's physiology with an aim to reduce mortality, prevent morbidity, but despite whatever we do, the mortality continues to be very high, even the morbidity continues to be very high. And this phenomena now you have seen in India also. During the last months of life, the ICU admissions are increasing. Earlier, the good death was happening at home in family environment. Now most deaths are happening in the hospital. So that has increased by 30%. And normally the ICU physicians, because they are mortality centric, they want to save lives, they do not accept any adverse outcome, or they do not want to talk about situation where they cannot offer anything much, and they have to discuss end of life care issues. So but now of late there has been a change. We accept that yes, we have reached a stage of medical futility, nothing much can be achieved. Now we have to discuss, support the family, support the patient, provide symptom control, and also work towards a dignified death. So withdrawals and withholdings, we had the discussion, are happening commonly in ICU now. Of course, documentation is important, but these discussions are emotionally draining. They take time. You don't have time. You have a lot of patients compared to your Western counterpart. So what are the difficult areas that the intensivist faces? Initiating such discussions. So we try to avoid knowledge and competency in withholding and withdrawing interventions, whether the team is clear about how we can go about this, whether it is allowed legally, and resistance to some of the treatment limiting the suffering. So team members may religiously feel differently, so that conflict is also there among the physicians as well as among the nurses. Then we are not familiar that we can use sedative analgesics just to ease distressing symptoms rather than as part of the curative treatment. We are not well versed with symptom management. Most oftentimes we leave it to the judgment of the nurses. When it is pain, thirst, anxiety, sleep disturbances, dyspnea. So we want to intervene with definitive measures when there is a measurable outcome. Other things, okay, ICU mein hai, dard thoda hoga, anxiety hai, thodi si sedative. So the nurses do a lot of things on their own. And we seldom provide psychological support to patients and their families because they come and visit us for a short period of time. Indian ICUs are very large, so our argument is we cannot talk to all of them. So, but we should at least be talking to those whose family members or loved ones are very sick. And also, we do not know how to manage depression, fear, anxiety, fatigue, anger, anorexia in the patient as well as their families. Nobody has trained. This is not part of the curriculum. So this we have, many of us and most of my colleagues have learned by experience. But mostly it is the senior people in the department who are doing it. So it also stresses them out. On the other hand, palliative care focuses on distressing symptom management. It also covers physical, psychological, and spiritual aspects. The principal domains that have been identified with palliative care are relief of distressing symptoms, effective communication about care goals, that we have reached this stage. Now we will be focusing more on comfort, care, and symptom relief. Patient-focused decision making. So whatever decisions we are taking, the patient is at the center of that. That's what Dr. Girish also pointed out. And caregiver support. The support has to continue across all care settings. So that these are some of the cardinal domains. Now, why we need to realize that lot of our patients, I'm not making a demarcation because Ashutosh said let us not demarcate oncology, non-oncology. All terminal patients where there is a situation of medical futility are same. It is easier to talk to the families, I agree, when they have an oncology terminal stage 4 cancer, metastatic cancer, compared to when they have non-resolving sepsis or multi-organ failure. But the situation is similar. So patients may experience distressing symptoms almost as 1/3 to 2/3 may experience this. More than 30% may feel delirium. And it has been seen that almost 20% of the patient reach the trigger targets where palliative consult is required. We don't do that in India, so we may be missing this. Families who are involved in care of their loved ones who are admitted with us, they are anxious. 80% is the anxiety, 57% have traumatic stress, and 80% are depressed. Please understand, all of them may be working, doing a job, so to leave their job for months together or years together in case of oncology treatment, it is very stressful on them. And then when the patient is not going to make it, we start end-of-life care discussions. It is very depressing for them. It's a once in a lifetime situation for them. So we need to understand that patients where aggressive curative treatment is not helpful, there we need to maybe shift them to palliative care. Madam asked about it. If we have those units, the concept is there, then maybe we can send these patients to the palliative care units. So there is a need for us to be empathic and care for the family as well as for the patient. There's a strong need, because that is what you need. That's what everybody needs, when they are dying. They want their loved ones to be around. They want, to be free of pain or free of any dyspnea or other symptoms. So a lot of studies have focused on barriers and risk of implementation of palliative care. Why in ICU? Why we can't do it? The barriers are, I'm not aware of the palliative care needs or the concept. I am not competent to screen the patients for need of palliative care. I have difficulty in communicating with the family at the appropriate time. And I also understand that when I'm applying the principles of palliative care, I'm hastening death. I'm not comfortable with this. My training is inadequate, or I do not have dedicated staff who I can call for a secondary palliative consult. That is not available. And oftentimes the patient as well as the family take palliative care discussions inappropriately. That doctor is trying to shrug away from his responsibility. Time and cost to train critical care clinicians for palliative care. So these are all important things. And then of course there are certain risks. Now the suggestions has been that what we can develop, what we can do is, in terms of interventions, from patient perspective, he needs freedom from pain and other symptoms. We need to prevent something called post-ICU syndrome, and the palliative care discussion has to be tailor-made based on the trajectory of the illness. As I showed in the beginning, as the illness severity is increasing and there are very few treatment options available and the medical treatment is futile, that is the time we should discuss it, rather than initiating discussion when patient is almost going to die. From family perspective, it is patient and family centric discussion. Emotional and practical support. Structured family communication, maybe a brochure which we can hand over to them. I do not know how many hospitals have a brochure regarding this, which highlights the palliative care, that once your patient reaches a certain stage, we'll be talking about these things with you. And also, if we have somebody who can communicate with the family on a daily basis, understand role of social worker is very, very important, especially in the oncology settings. I feel it is important, equally important in a general intensive care unit also. Clinicians, we need to do a lot of things. Then in terms of systems and other things, we need to, so there are suggestions given which we need to look at. Generally, by and large, if you look at the indications for palliative care, they are elderly patients where, we know that they have aged so much. They are 94, 95, 96 plus. Patients who have been with us for many, many days, many weeks. Patients who have multiple comorbid conditions which are fairly advanced, or where there is an advanced medical directive. Now this is common in the Western world, but I think next decade we'll have this also being reported from Indian hospitals. Conditions where physicians feel that we cannot offer anything more and any further interventions are futile. So these indications for requirement are there in up to 20% of the ICU patients. Lot of studies have identified when they have given palliative care consult to a palliative care specialist. So you can see when a patient was in hospital for a long time, when they had a advanced stage 4 malignancy, post cardiac arrest, major ICH bleed, on ventilator, etc., etc. And again, you can see where they feel patient was unlikely to survive for more than a week if the treatment was withdrawn, not escalated, more than 3 organ failure. And also when there was disagreement among patients, staff, family, resuscitation preferences, or use of feeding, hydration, or other major treatment decisions, then also these they wanted someone else to help them because they were not making any headway there. So that is where the palliative consult was given. One example is this paper which was quoted in the White Journal, early palliative care for patients with metastatic non-small cell lung cancer. Now it is very illustrating. They looked at these patients because this cancer has substantial symptom burden and generally aggressive treatment may be continued until the end of life. So they divided the patient randomly to either receive early palliative care or continue with the standard oncological care, and they assessed the quality of life and mood. They also looked at the hospital anxiety and depression scale, their anxiety and depression, and the primary outcome was quality of life at 12 weeks. So you can see all the scores were better in the early palliative care, and if you look at the anxiety, and depression, the HAT score, you find that this is the standard care. It came down significantly with early palliative care. In terms of patient survival also, early palliative care was better. So these patients fared better. So what they concluded was palliative care led to significant improvement in quality of life as well as mood. And these patients, they had less aggressive care at the end, but they had longer survival. So they found it was beneficial. Another paper highlighted that early palliative care reduces end-of-life care use, but not ICU course in patients with advanced cancer. So this looks at the primary outcome. Just see, the care group is where early palliative care was initiated based on a standard protocol. So look at everything, the number of patients who died in the hospital, died in the ICU, enrolled in hospice is much more, 209 versus 75. So what they found is when they were continuing with the early palliative care, more families opted for hospice care. Now this can significantly reduce ICU admissions towards the end of life, and there can be fewer deaths in these patients happening in the ICU. And it does not change the ICU experience of the patient who require critical care. So overall, they found that there was a lot of benefit in terms of patient moving from the active intensive care unit to less active or palliative care or symptom-based palliative care units or to hospice. So my final remarks are, ICU patients need palliative care. Palliative care integrated with intensive care is the way forward. And ICU physician, we all need to be trained in concepts of palliative care. Fortunately, there is a good document available. Ashutosh mentioned it. Joint document developed by our society and the Palliative Care Society. So I think we need to implement that. Specialized palliative consults may help in difficult situations, provided we have these group of consultants available with them. They need not necessarily be doctors, they can be nurses, physiotherapists, other people who are trained in this aspect. And we need to understand that we need to look at the patient's symptoms, pain, suffering, and provide psychological support. And lastly, humanizing critical care is very important. Thank you very much for your attention. Thank you.
Thank you so much, Dr. Rajesh Pandey, sir. It was really a wonderful talk, and I am really happy. I would like to congratulate the organizer, Dr. Praveen Kaur, especially to keep these sessions where we are emphasizing more on the palliative care and end-of-life care. As we as intensivists, not only intensivists, we as physicians, we try to jump on more on the intensive things, more on the treatment part of the patient. But yes, it is important, and it is an important aspect of the treatment to provide the palliative care. And I think till this palliative care facilities are more abundantly available in our situation. This home care facility, can it substitute this palliative care? What do you think, Dr.
Hospice care is a part of the palliative care. I mean, patients, they should be with their families where nothing much is there, psychological support, physical support, maybe some kind of symptom relief is available. So I think the oncologist may be more familiar. I know only about one hospice center, that is in Safdarjung Hospital. So I don't think there are many such centers in India.
But those who are providing home care, there are.
Oh, you were talking about home care. Sorry.
Yeah.
Home care is another area which, again, it may not be the substitute, but it may be a good option in country like India.
Yes.
Because the patient is, somebody who is very important member. He may be father, he may be mother or wife. If they are in their home environment, they definitely do better. This is what we have seen to critically ill patients who are taking long time in recovering. They do much better at home. So they are in their home environment. They have somebody who can look after their needs, and they die with dignity at home when everybody is there. So this could be one model, but the Western model doesn't talk about it because they find it, they do not even think about providing home care.
But till the time we have more of palliative care centers
We
and
can,
hospices,
we can. I think this is being practiced also.
yes. As ma'am was asking in the end of the earlier panel discussion, that there are many a times you face a situation when the attendants want the patient to be shifted from ICU to ward. So there we can offer them that services.
Are there any questions from the house or any comments from the house? Anyone? Okay, just one thing that I thought is important, and home care is, when you have a patient who's at least reasonably stable enough, or completely written off in terms of taking him home, but you have patients within the hospital who require some amount of continuous care, yet they need mainly palliative care. I think that is a something which we really need to closely look at. And one thing I noticed, because Parveen, before you came, I happened to look after this ICU myself for about a year or so. The experience was that when you mix patients who require very intensive care with other patients who are actually terminally ill, it takes away the enthusiasm and the kind of zeal of the people who are working there, because on one hand you have people who are DNI, etc., and on the very next bed you have a patient with sepsis who requires all your attention. So there, there is a problem, and I think that you need to seriously look at having palliative intensive care. I'm just for short of a better term, palliative care where there is that provision of monitoring and etc., but the family members can be there. Their visits are not limited, unrestricted, things like that, and where the discussions have taken place about not intubating, etc., but not mixing the two.
Yes, sir.
Because there is a problem.
So many a times this discussion has happened, because over a period of last 26 years, many a times this request for a palliative separate kind of a thing has happened. But now I think in the last month's meeting it has been decided I will designate 1 or 2 beds. But I will also like to state here, sir, that 1 or 2 referrals which had come to our team, and we actually examined and spoke to the families, they were not willing to for a hospice or a home care solution at all. They still wanted an institutional depth.
Precisely. So
So
they would
No,
want to.
I agree. Institution care becomes important. The point that he's making is very valid, because
It's a different
oftentimes
point.
you have to treat
You're
their
not saying
pain and their
no.
symptoms. At home, the doctor would not be visiting.
Yes,
It will be
sir.
limited
Yes,
to
sir.
the
But
nurse
again,
or the attendant.
So the hospital management mandate about being a curative institution rather than a palliative. We don't want, because then it will be like cutting down on curative beds if we want to create. We have a fear that it may have to be
that is a call
expanded.
you have to take.
But that
back.
is one way of looking
that
at
is
it.
something- That's why it
Nevertheless.
has not happened till now, I feel.
Nevertheless.
Because 8 bed, 10 bed, हो सकता है demand becomes so exponential that we may not be able to meet it.
बट ये जो है ना, ये एक मसला है।
या,
और
मसला
मतलब
तो
कि-
है।
हाँ, मसला है।
मसला
और
तो है।
ये मेरे सारे बैठे हुए डॉक्टर आनंद और ये
So
सतीश
2
वगैरह
beds
सारे
is what
बैठे हैं।
last month I got कि 2 beds बना लेते हैं. I'm
And
still
it is
thinking about whether
very
we should.
draining on the nurses, on the staff,
Yeah.
because they are seeing patients, terminally ill patients, just pass
Yeah,
out like
yeah.
that, and that takes away their energy, because they don't sort of feel as energetic. It's a practical problem.
Dr. Rajiv, I have given this suggestion to NABH that if a hospital has 50 or 100 cancer beds, or they make it mandatory for them. If it comes from them, तभी होगा, नहीं तो नहीं होगा.
तब तो कर ही लेंगे सर.
I have one point to make here in continuation of what Dr. Goyal has and Dr. Pandey has highlighted. Is fact that a lot of times the primary onco physicians and the consultants they do not want to label their patients as palliative patients for whatever reason. And they do not want to shift their patients out of ICU even if they have given DNI.
Ashutosh, it is because they are equally ignorant about the concept of palliative care as we are. Because I don't think
Yeah.
legal issues.
Are there any other questions from the house? Anybody, any comments? Dr. Pandey, thank you so much.
Thank you, sir.
It was
Thank
a
you so much.
really brilliant lecture, and thank you for coming here.
Thank you.
And thank you for looking after the panel discussion and this stuff. Thank you so much.
Thank you. Thank you.
Thank you, Kapil.
Thank you so much, sir. May I now request our chairpersons to kindly felicitate the speaker, Dr. Rajesh, once again as a speaker. Sir, please. I would now request Dr. Yeah, we just. I would request Dr. Pinky Yadav ma'am to felicitate the chairpersons. Dr. Rajiv and Dr. Kapil Singhal. Thank you, sir.